So we can start off so that we don't lose some time. Good morning, good afternoon, colleagues, friends, and everyone else. Today, the 9th of April, we want to welcome each and every person taking part in the Rain and Shine. I think this is the Rain and Shine 3, and we'll be talking about engaging communities in pandemic governance. And this is towards building resilient community systems. So today we have a full-packed program. Before I proceed, my name is Olive Mumba. I work within the Community Rights and Gender Department, and I'm together here, you can see with my colleagues, starting with Gavin Reed, he'll be speaking very shortly, and then Jonathan, he'll be taking us through the Amenti, and Sharon. I would like to welcome each and every other person. If we can go to the next slide so that we can just look at the agenda. In terms of the agenda, it's fully packed. We'll be having opening remarks from Gavin and from James, and then we'll continue. Rachel will give us an introduction to what the Community Engagement and Leadership in Pandemic Governance project is all about. Then we will go on to Jerry, who will take us through a guidance note that has been developed through this piece of work on the community engagement and leadership in pandemic governance. And then we'll have a mentee that Jonathan will lead. And then after that, then we'll have country partners from Kenya, Philippines, Cambodia, and Cameroon present findings and lessons they have from implementing the program. And then we'll have some few minutes for question and answers. Then Rain Cortez, my colleague from the Global Fund, will also take us to the next step. After CELG, we have what is called the community engagement in pandemic preparedness and response. So we have two components, the community engagement and community-led monitoring. Then we'll have closing remarks. So with that, let me quickly move on to the person next on the agenda, that is Gavin. And then immediately after Gavin, please come on in, James. Over to you, Gavin.
Thanks so much, Olive, and good morning, good evening. Good morning and good evening to all our colleagues. And just to appreciate the leadership of all the TB partners in the 8 countries, plus that of ACT Asia Pacific, hosted by APCASO, ACT Africa, and Stop TB Partnership. Meaningful community engagement in the context of health responses is defined by us as where communities are consistently and continuously acknowledged in decision-making and processes, and where their unique expertise, perspectives, and lived experiences are sought and valued. And I think it's important to really recognize that communities bring expertise. So it isn't just a case of a principle around their involvement, but it's actually about the value add. So whilst the Global Fund has been widely acknowledged for our approach to community engagement since our founding, with communities playing a central role in governance at country and global levels, as implementers, in accountability, and in advocates for the mission, the Global Fund strategy now includes a contributory objective to maximize the engagement and leadership of most affected communities to leave no one behind, and commits us to put communities at the center of everything that we do. As I said, community engagement is not just a principle, but there's extensive evidence on the importance of community engagement. An analysis consistently shows the connection between communities empowered to engage in decisions that impact their lives, and the criticality of building trust between communities and other actors in health responses to ensure the effectiveness of interventions programs and to ensure that systems are responsive to actual and changing needs. Drawing from the lessons during COVID response and the effect on the TB response, it's essential that we recognize the priorities, perspectives, and expertise from TB, key and vulnerable populations, and TB serving actors. To this effect, we've been collectively working to engage last mile populations, including slum dwellers, ex-prisoners, people with disabilities, internally displaced people, migrants, and refugees. And COVID-19, just as HIV and Ebola and other epidemics, underscores the significance of addressing human rights and gender-related violations and barriers to services, and the importance of integrating community-led responses into programs whilst building trust. Trust is a prerequisite to agile, timely, and effective detection and responses to pandemics. Through CELG, communities have been able to identify the needs to strengthen the participation and voice in pandemic governance platforms and processes, and has also built knowledge through timely, accurate PPR-related information resources. As we shift from COVID-19 to pandemic preparedness, we need to ensure that there is more widely available information. We need to build PPR literacy and to strengthen the capacity, as well as establishing and enhancing coalitions and partnerships to support meaningful engagement and governance. Today is an opportunity for us to exchange and to learn from our collective work during GC6 through CELG, and to orientate ourselves what lies ahead in GC7 through COPPA CE and COPPA CLM. And with that, I'll pass over to James.
Hi, everyone, and thanks so much for the opportunity, Olive, Gavin, and all the team, and all of the partners from the side of Stop TB. It's been great to be a partner in this initiative and to sort of see it progress. I guess there's a couple of opening comments and remarks that I wanted to sort of share as part of framing this discussion. I think firstly, it's very much, thinking back to where some of the thinking for this initiative came from. And as Gavin was mentioning, a lot out of the COVID-19 and the C19 response mechanism. And one of the things that's interesting here is we recently heard, or the end of 2023, from TB communities in a report entitled A Deadly Divide, which is a TB community accountability report, that one of the priorities for communities was to ensure that TB was the central theme when looking at PPPR. And there's a number of reasons for this. And I think first and foremost, we saw with COVID-19, and all of the evidence suggests that for the next pandemic, both are airborne, very much like TB. We also know that a lot of those communities who are most vulnerable and who are most marginalized for COVID-19, for future pandemics, and for TB are those who are most vulnerable in our society, those who face the greatest human rights violations or the most significant human rights barriers to access services. So there's this critical need, I think, to be really looking at how are we engaging and mobilizing TB affected communities, not just for the TB response, but in its own right, that is an important goal, ambition, and something we must achieve, but for broader health responses, as Gavin articulated. So a couple of things that I think would be useful to just sort of add here, and I think over the contribution of community engagement in CRG and global fund responses has been significant. But one of the things that was noticeable from the TB side of things is that there was a lack of nuance towards what this means for TB. And one of the things that I think has been a really important development is now we have a clear definition of what CRG means for TB, and it has 7 pillars. And 2 of those pillars I think are really relevant to our conversation today. One of them is looking at that question of key and vulnerable populations. Who are they? Why are they being prioritized? What are those human rights violations that they face? And the second pillar that I think is particularly relevant in terms of TB-CRG and this discussion today is that of participation. What is it that it means to participate in all components of the TB response? And as Gavin had said, what does it mean to have a valued and meaningful contribution to that response? So those are sort of 2 points that I think are really important developments in recent years that set up this discussion in an important way. Now, beyond that, I think it is also really important to think about when we say meaningful engagement of whom, and engagement of communities. Now, unfortunately, for many TB communities, there has never been that focused, concerted effort to really mobilize at a grassroots level. And this is something where I know that there's been efforts from a number of partners to really take this forward so that we do have TB survivor networks at country level in all countries who are ensuring that there is meaningful engagement, because it is very difficult to have meaningful engagement without organization, without coordination, without capacity, and without investment. And so this is something that's a key consideration as part of this initiative, and will continue to be going forward. From the side of Stop TB, we've been really happy to see the growth of Challenge Facility for Civil Society as a mechanism that is really trying to fill this huge gap, to make sure that we do have TB survivor networks at country level, networks who are not just involved, but and are not just capacitated, but also have that leadership capacity, that they're the recipients of grants and manage those grants themselves. And I think that that's also something which is, you know, an important contribution to this and will continue to be going forward. So as part of this discussion around those key and vulnerable populations, it is really important to acknowledge, I suppose, in TB, that key and vulnerable populations have traditionally not had a major role in TB responses and in PPPR, but there is new opportunities there, and there are new platforms and networks to build upon. Now, just in TB recently, we've seen the launch of the TB Key and Vulnerable Population Size Estimation Tool. And this is something that can support countries to really prioritize, based on human rights barriers, those populations that require nuanced health responses, that require specific programming, that are required to be engaged, empowered, invested in, and who need to be at the table, make that valued contribution. We know in TB it is very much been a generalized epidemic and generalized responses, but to reach the missing millions, to find the missing people with TB, we need nuanced sort of programmatic and policy related responses. And this is relevant for TB, but also for PPPR. So I think with going forward and sort of reflecting on some of the initial work that's been done, I wanted to sort of applaud and congratulate all of the partners for your efforts at regional and country level. I think that we are starting to continue a really important discussion. It still remains in its early stages, but I think that there is a lot of opportunity to continue to build, to engage TB survivors, key and vulnerable populations in TB, in pandemic preparedness and response. And it is something from the side of Stop TB that we've been really happy to partner with Global Fund on, and with all of you. And we look forward to continuing to do that. Back to you, Olive, and thanks so much.
Thank you so much, both James and Gavin, for the introductions, for the opening remarks, and also for taking us a step back to just reflect on communities and who are these communities that we should be putting in the forefront, and why is it key for us to have TB, key and vulnerable populations, part and parcel of decision-making when it comes to pandemics. Thank you so much. I would also like to thank Jeff and Rachel at both ACT Africa and ACT Asia Pacific for hosting this meeting. But also we have the learning hubs from the Community Engagement Strategic Initiative who are facilitating the translation. So just make sure that you have, if you are connecting in French or in Spanish, there is a section where you can, there's a section on translate, where interpretation, where you can choose the language you want to speak in. With that, there is also a chat box where you would want to introduce yourself, the organization you're working with, your name, your organization, and the country you're coming from. And as we're moving forward, in terms of the next point in the agenda is presentations. If you have questions or comments, please let's use the chat box. So now we are moving forward to what the community engagement and leadership in pandemic governance is all about. We are having a presentation from our colleague, Rachel, who has been in the back, one of the project coordinators for ACT Africa. Over to you, Rachel. Thank you.
Thank you very much, Olive. Good morning from Ghana, colleagues. Good morning, everyone. And this morning, I'll be taking you through what community engagement and leadership in pandemic governance has all been about. But first of all, my name is Rachel Otu-Amponsa, and I work with ACT Africa, as Olive has already stated, and I'm the project coordinator for CELG. And so my presentation this morning will basically cover the following. why community engagement in leadership and pandemic governance, and the countries covered, objectives of the CELG, the process of the assessment, findings from the assessment. Next slide, please. Now, why CELG? The impact of COVID-19 was basically felt differently across different populations with different vulnerabilities. So now there was a C19RM survey that was conducted, and this survey suggested that there were some people who have increased vulnerabilities and risk, but these people's responses were not captured in the survey. So who were these people? The people identified were basically slum dwellers, people in prison or ex-prisoners, people with disabilities, internally displaced people, public transportation drivers, and then internal migrants, and also nomads. Yes, next slide, please. What was the objective of this project? The objective was basically to identify, test, and document engagement strategies, approaches, and processes, basically to enable the LMPs or KVPs as part of TB networks to influence COVID-19 and PPL decisions, and also identify and facilitate access to technical support, and of course, embedded lessons from COVID-19 and proven processes into the Global Fund processes. Now, this project was piloted in 8 countries, so 5 African countries and 3 Asia-Pacific countries. Cambodia worked with migrant workers. Cameroon worked with internally displaced persons, IDPs. Indonesia worked with former prisoners. Kenya worked with people with disabilities. Mozambique with minors, ex-minors. Nigeria worked with nomad IDPs. Philippines worked with tricycle operators and drivers associations. And Sierra Leone worked with people with disabilities. Now, to enable us achieve the purpose of the project, we had to develop a tool. And so the objective of the assessment tool was basically to identify barriers, opportunities, and provide recommendation, basically on how to strengthen the engagement of the last mile population in national TB and then COVID-19 PPR, and also to collect information on the structures, processes, and national and subnational COVID-19 PPR response platforms and policies, and basically to identify opportunities for engagement. And thirdly, to collect information on the key partners working with the last mile populations involved in the national TB response, as well as national COVID-19 and PPR response, PPR. And lastly, to develop a community costed engagement plan to be used by partners as they prioritize activities and develop a national LMP engagement plan in pandemic governance structures. Now, the assessment process was basically structured in this way. We have the pre-assessment preparations where we had multi-stakeholder orientation meetings. We had multi-stakeholder steering committee. We had country level consultants, and then we had the orientation of the country and then country team on the tool. Now, the steering committee was basically made up of individuals from LMPs, TB Network, National TB Programs, Country Stop TB Partnership, and then other technical partners. And so the community engagement assessment involved data collection, the analysis, the pre-validation focus group discussion, and then the reporting and the implementation stage. Just to give it in a graphical view, but basically the same idea. We have the pre-assessment preparation, the community engagement assessment, which involves surveys, focus group discussion, key informants interview, and then pre-validation focus group discussion. We have the data analysis and reporting, country level validation meetings, and then the reports. Now, in order not to jump into presentation of the country partners, I just fished out some of the key findings from the assessment. And the assessment basically showed that there was lack of information on TB and PPR when it comes to the last mile populations that were identified. It also showed that there were limited awareness and understanding of national and community TB response and coordination mechanism. And lastly, there was a huge gap in communication and community involvement with the last mile populations that were identified. Now, what is the next step? There's the need to focus on building information about pandemics using TB and universal health coverage as an entry point. And also there's a need to address structures as a foundation for stronger health systems. That'll be all, everyone. Thank you very much. And over to you, Olive.
Thank you so much, Rachel, for taking us through what CELG did in terms of the assessment, but also in terms of the engagement plans. Though we've not really seen what the engagement plans look like, we will be getting to that section when we have the country partners do their presentations. We are now moving on. As I mentioned, if you have a comment or if you have a question, please put it in the chat box. There's going to be a section where we'll have a question and answer, or if you want to provide a comment, we'll have that time. So now we are moving on. We will be having Jerry. Jerry has been a consultant that has been supporting ACT Asia Pacific to moderate and manage the community of practice for CELG. I won't say a lot, but Jerry, if you can just introduce yourself and please take us through the next section. Over to you.
Hello, thanks, Olive. Hello, everyone. I'm Jerry Maya Carlo Alejo. I'm a physician in the Philippines, but I've been working in a municipal health government for the past 4 years. Currently, I'm involved with CELG, and I'll be part of the faculty of the Community Health Nursing program in the University of the Philippines. So I was involved with developing the curriculum for the CELG Learning Hub, and this includes facilitating several webinars in relation to facilitating the sharing of knowledge regarding the participating organizations' activities in relation to engaging the last mile populations. So this presentation will be focused on the development of a manuscript based on the experiences of the organizations in strengthening the last mile population engagement in health and pandemic governance. Next slide, please. So as Rachel discussed earlier, the CELG project is composed of 8 countries, engaging several last mile populations from each country, as described above in the screen. And the next, please. So the CELG in Leadership in Pandemic Governance Knowledge Hub is actually a 2-pronged project. One involves the webinar series as well as a website which serves as a repository of the learnings and the knowledge, and as well as the several resources that we have used during the discussions for the webinar. Next slide, please. As an extension of the CELG webinar series and the website, we wanted to make sure that the lessons that the organizations have learned during the webinars as well as their experiences do not stay with them. The CELG group decided to write a manuscript based on the activities that the organizations did. So the purpose of the manuscript basically is to share the lessons that the organizations have learned in working with their TB LMPs. And the following will be parts of the manuscript. One is the documentation of the assumptions and the rationale behind the project. The second is to describe the identified expected outcomes related to LMP engagement in health and pandemic governance. And 3, to discuss the strategies or the action areas in strengthening the capacities for LMPs to engage in health and pandemic governance. So based on this purpose, the following will be the outline of the manuscript. Next slide, please. So the first will be the introduction and the background, the first part. The second will be the expected outcomes in strengthening capacities for LMPs. The third would be the discussion of the actual areas of action that the country partner country organizations did to facilitate the engagement of the LMPs in platforms for health and pandemic governance. And then the fourth will be a short discussion on the initial results of the implementation of the CELG engagement plans of each country partner. Next slide, please. So for the background introduction, it will discuss basically what Rachel had discussed. So it will define last mile populations in the context of health and in the pandemic, as well as TB program services. The second will be a brief overview of the CELG as a platform for engaging the LMPs. The third would be the effects of the COVID-19 pandemic on the TB
Hi,
last mile
Jerry.
population.
Sorry, this is
Yes.
Jeff. Can you speak a little slower for our translation? Thank you.
Okay, thank you. The effects of the COVID-19 pandemic on the TB last mile populations, based on the experiences of the population groups that the country partners engaged with. The fourth one is the community engagement in health and pandemic governance, the different platforms and baseline documents that serves as a rationale for the last mile population engagement. And again, the purpose of the manuscript. So basically, we'll be using the definition of the UNDP with regards to last mile populations in health. And it says that by the last mile, we are referring not only to the poorest of the poor, but also to the people, places, and small enterprise levels that are underserved and excluded, where development needs are greatest and where resources are most scarce. Millions of people are not benefiting from, because basically millions of people are not benefiting from the fruits of development, especially the poorest and those disadvantaged because of their sex, age, disability, ethnicity, or geographic location. So this serves as the basis for identifying last mile populations as partners for engagement in TB programs, as well as in general health system strengthening. Next slide, please. So among the TB last mile populations identified or engaged with during the CELG project, the following were the common vulnerabilities. The first is the increased exposure to infectious diseases. The second is the lack of access to health services, including health information, due to poor resources, both from the side of the last mile populations as well as the healthcare providers. The third is the limited representation in health governance decision making, basically because of the non-organized nature of the LMPs. The second one is the lack of platforms within governments to facilitate their engagement. Specific vulnerabilities identified by the CELG country partners include occupational exposures, as in the case of miners and garment factory workers, stigma and societal distrust in the case of nomads and internally displaced persons, physical inaccessibility and communication barriers, as in the case of persons with disabilities, and in general financial inaccessibility, particularly of those who dwell in the slums. Next slide, please. And because of the COVID-19 pandemic, as well as the specific vulnerabilities of the last mile populations, the following have been the effects of the COVID-19 on the last mile populations. And it was seen during the study, as presented by Rachel, that the last mile populations were not given focus as much. So they were the victims of the following effects. The following include disruptions in the delivery of services and administration of programs. One, due to travel restrictions and interrupted supply chains. The second effect would be the avoidance of consultation on the side of last mile populations and other patients due to fear of implications of being identified as a COVID-19 suspect. The third would be poor utilization of preventive services, basically due to misconceptions about diseases and health products among the last mile populations, again, due to their lack of knowledge about TB, about the pandemic, and the COVID-19, as well as the services available in the communities. Next slide, please. And the being rationale or main reason why we're working with LMPs is the belief that a chain is only as strong as its weakest link. After the pandemic and with the recognition that health system strengthening is part in preparing for pandemic resilience is a requirement for ensuring that our health systems is resilient in the face of other shocks. We recognize that improving the quality of healthcare and services and being responsive to the needs and preferences of local communities cannot be done without the individuals and teams responsible for designing, managing, and delivering healthcare, talking and interacting with each other, as well as engaging with service users and other stakeholders about how best to do this. So this is a quote from the World Health Organization Community Engagement Framework. So it highlights the reason why we need to engage with communities, especially those who are least able to access the services. Next slide, please. So that basically describes the purpose and the reason for the CELG project and the purpose for the need to share the lessons for the manuscript. The second part will discuss the expected outcomes in strengthening capacities for LMPs to engage in health and pandemic governance. So based on the discussions during the webinars, as well as the review of the different CELG engagement plans, it produced the goal of last mile populations as active participants in health and pandemic-related policymaking and service program design and delivery with the following two-pronged objectives. Next slide, please. So the two-pronged objectives include, first, is to develop the organizational and leadership capacities among LMPs to engage in health and governance. This includes facilitating the development of required health literacy in relation to TB and COVID-19, as well as the different services available to the populations in their own communities, as well as the national government. And the second one is to facilitate an environment that is conducive to their engagement, specifically to create and strengthen health and pandemic governance-related platforms for community participation, particularly last mile populations. So based on these objectives, the third part of the manuscript, next slide please, will focus on the different areas of action for building the capacities of LMPs to engage in platforms for health and pandemic governance. The following 5 action areas were based on the discussions, again, during the webinars, as well as the CELG engagement plans of the 8 countries. So the first action area would be identifying and assessing the needs, capacities, and resources of LMPs. The second would be organizing and capacity building activities for the last mile populations as reflective of the second objective. The third would be establishing and strengthening platforms for LMP engagement in health and pandemic governance. The fourth would be addressing specific vulnerabilities, removing barriers in the social determinants of health that prevents our LMPs to engage and access health services. And the last would be focused on determining capacity building activities for the civil society organizations engaged with LMP representation, facilitation, or capacity building. Next slide, please. Since the project is part of CELG, the first action area, identifying and assessing the needs, capacities, and resources of LMPs, will focus on the summary of the community engagement assessment tool that was produced by ACT Africa and ACT Asia Pacific community engagement project. So this involves determining the levels of participation by the LMPs, and then determining the strengths, weaknesses, opportunities, and threats available to them to engage in pandemic governance and health system governance. Next slide, please. The second CELG area of action would be LMP organizing and capacity building, and this would include the activities of the partner organizations in relation to information and education and campaigns on key health topics such as TB, COVID-19, PPR, the available services and platforms, available health services, as well as the platforms for engagement with government and other institutions. Next slide, please. The second main activity as part of LMP organizing and capacity building would be the committee or group organizing as well as leadership development activities. And this would focus on strategies or actual activities that the different CSO country partners engaged in, including areas such as advocacy and developing the LMP's skills in advocacy and representation, the different communication models and channels that the LMPs may use in order to raise their issues as well as to participate in policy making and health service development, linkaging and collaboration, ensuring that they have funding and sustainability for their efforts, and developing the capacity to develop plans of actions, as well as monitoring and evaluation plans. Next slide, please. Another key activity that was as an offshoot of the discussion was in their CELG plan was developing the LMP's capacity to determine where they can find incentives and support for participation and representation. And then last would be part of their capacity building activities would be facilitating network building and linkaging. Next slide, please. The third area of action would be establishing and strengthening platforms for LMP engagement in health and pandemic governance. So this would include a discussion on how stakeholders related to LMP engagement and representation was mapped, as well as what were the basis for identifying stakeholders that need to be engaged with. And then after stakeholder mapping, this would include what activities were done and what was the purpose of advocating for LMP engagement with particular stakeholders, as well as the methods that the different CSO partners, as well as the organized LMP groups that they utilized. Thank you. Next slide. The third part of the activities related to strengthening platforms will be coordinating for LMP engagement planning in health and pandemic governance and service delivery, particularly with national governments or district level governments, as the case may be, as depending on the case as needed on the area where the activity was done. And this would include facilitating communication among stakeholders, particularly LMP with language and communication barriers. The fourth would be developing monitoring engagement for LMP engagement and representation. Next slide, please. The last parts for the CLE areas of action would be, again, determining the CSO capacity building for strengthening LMP engagement. And this would discuss recommended CSO capacities to develop LMP engagement and strengthening. And the last part, in recognition of the vulnerabilities of the LMPs, would be addressing specific vulnerabilities. Next slide. The last part of the manuscript would be the initial results of the CELG engagement plan implementation, and this will be discussed for three stakeholders. One is for the CSOs, and initial outputs include the development of scalable engagement models and development of training designs for LMPs related to TB and COVID-19. For the LMPs, the formation of committees and identified leaders and champions who are now engaged in TB policy, TB and COVID-19 policy making and service delivery designing. And for the institutions, the creation of communication channels, inclusion of decision-making processes for policy and program development for LMPs. That's all. Thank you.
Thank you so much, Jerry. I think you took us through a long process of what's coming out and discussions that were held through the community of practice. And probably the next session, I think we'll also highlight why why are you talking about that, and how were those areas prioritized. But before we move to the country presentations, let's do just a small. I'll hand over to Jonathan to take us through something.
Fantastic. Thank you so much, Olive. And also thank you, Jerry and Rachel, for a great context of the CLG. Now that we've heard all this, we wanted to hear a bit from you before we go into the country experiences. So as you can see in the screen, we're going to do a little Menti. If you could go on your phone on menti.com and enter the code. I've put that in the chat as well, or go ahead and use the QR code. I'll give you a few seconds, then I'm just going to go ahead and share my screen so we can go ahead and see the results. So I'm going to do that right now. It's also in the chat, so please feel free to go ahead and go there. Here we are again. So I can't exactly see how many people we have. Okay, give a little thumbs up once you're online so I can see how many people. We've got around 4, 6, loving all of these. Yes, we're warming up. All right, so let's go to our little first question in that case to get us warmed up a bit. So why is it important for communities to engage in building agile systems that respond to pandemics? Is it to build community trust in response systems? Is it perhaps to reduce gender-based and human rights violations? Or is it for risk communication and to mobilize communities to support access to services? All right, I see we have a lot of the first one. I'll give people a little chance. If you haven't connected yet, you can see the code at the top normally. All right, I'll give you a few seconds. So I'm seeing to build community trust in response systems. And our answer is not showing, but it was actually all of them. Trick question, we like to have fun, but indeed all of these three are of exact same importance to build agile systems that respond to pandemics. Now we've warmed up a bit to think, to help us also give you your say, we wanted to hear one more thing from you as well. So in one word, why is it key to engage communities in pandemic readiness? Please feel free also to enter your answer in your own language if that is easier for you. But just answer a little bit, one word on why it is key to engage communities in pandemic readiness. Brilliant. So I'm seeing trust, resilience, frontline, because they're neglected, because they're underfunded. Seeing resilience, seeing surveillance, health for all, capable. We're getting a lovely word cloud here, yeah. We will share this in the end of the session as well, along with a slide and the presentation, so you can see a little bit of what people had to say. Fantastic. Health for all. Trust is a big one I'm seeing. Frontline, empowerment, surveillance, top 3, top 4. Nice one. Great, I'm seeing it's the right. Health for all, yeah, voices out. Brilliant. While that continues, we're going to ask one last question before moving on to our awaited country experiences. So I'm just going to move to the next slide, but please, if you want to carry on answering, you can. So what we really want to hear from you is, what have you heard of or seen perhaps in your experience that has been effective in supporting communities to engage in PPR, pandemic preparedness response? So we're going to leave this up throughout the rest of the presentation, so you can answer now, but you can also answer during the presentations, perhaps during the country experiences. You may think of something or realize something perhaps that you would like to share. And of course, you can use as many words you want, submit as many responses. It'd be great to hear from you. And after this presentation, we will be sharing all of your responses. Thank you so much. After this little quick warm up, I'm ready to hand it over to Olive to present us with our next speakers.
Please don't stop populating that page, because we really need that information. Thank you so much, Jonathan. I think you were running at 180 kilometers per hour.
Catching up time, excited to hear about the country experiences.
So that we have time to listen to the country experiences, which I think is the most, not the least, but they are one of the most important sessions on this panel. So today we are having Joanne Waminga from Kenya, who will be sharing around their work, lessons in building the capacity and engaging last mile population, together with Shane Citadel from Philippines. And then we'll move on to hearing from both Shantron and Bernadette. They'll be talking about lessons in advocating for the inclusion of last mile populations in the national TB and pandemic response. I would like to request the two, Joanne and Shane, to start off. Please, if we could keep time, 10 minutes each, not more, because we are running out of time. Over to you, Joanne, please.
Thank you. Good morning, good afternoon, wherever you are. My name is Joanne, and allow me to start off with a brief introduction about Stop TB Partnership Kenya. It is a membership organization that was established in 2010, and apologies, I'm having challenges with my video and I'm unable to set it up to show pictures. Yeah, it's an organization that was established in 2009 and registered in 2010. And it brings together the national government, that is a TB program, the non-governmental organizations, the TB affected communities, academic institutions, private sector, and all this in a bid to engage them in TB advocacy towards ending TB in Kenya. So our main aim is to attain a Kenya free of TB and other related diseases. Our activities are about mobilizing and capacity building communities that are affected and infected by TB, either through CRG or even CLM, in order to engage them in the decision-making processes, and also the political advocacy, ensuring that TB remains high in the political agenda. Important to note is that the Secretariat for the National Parliamentary Caucus, as well as the Secretariat for the Network of TB Champions in Kenya. So next slide, please. Getting to the presentation, I started off with a definition of who LMPs are, and we have heard from the previous speakers that they refer to marginalized or the underserved communities who may often reside in remote places, but not necessarily, but they may also be found in hard-to-reach areas. Hard-to-reach areas may not be just the inaccessible areas, either due to the geographical location, but they could also be living within the communities that we are in, but due to factors here and there like stigma and discrimination, it may be hard to reach them because more often than not, they could be hidden in our homes or even in places of work. So some of the benefits of engaging these last mile populations is to ensure that we are tailor-making approaches that respond to their socioeconomic and cultural context, to be able to ensure that the interventions that we are putting in place are reaching to them either through outreaches, health education programs, or even strengthening the capacity of healthcare workers and even addressing the social determinants of health. And all this is to ensure that they get equitable access to healthcare and effective disease prevention control. Next slide. Yeah, there's some of the risks and vulnerabilities that the last mile populations, and in this case, we in Kenya are looking at the people living with disabilities, could be more at individual level and even at the country level. Just highlighting a few at the individual level could be access to information, and this could be based on their nature of disability. For people who have a vision issue, there could be challenges in being able to read materials that are often in print, displayed, be it posters, and those without hearing ability, again, if the messages are passed through the audio, then they may have challenges to access that. There is the essence of dependency on caregivers, and especially we saw this during COVID-19, where the people living with disabilities were hampered by the caregivers falling ill of COVID, and therefore they were challenged in terms of their day-to-day activities as they need or they are dependent on these caregivers. The restrictions, as mentioned earlier, were also a challenge, and there's communication barriers, as had been mentioned earlier, economic constraints, and this limits affordability, not just for the health services, but also for the assistive devices that would be able to assist them to move around and go about their day-to-day activities. Accessibility was also another aspect, and especially more so in accessing the healthcare services, either due to the terrain or even the movement that was restricted, even in terms of the transport. When it comes to the country level, there was low recognition of roles of people living with disability in the response at country level. The representation was an issue, and inclusion in decision-making processes, because primarily the people living with disability are seen to have beyond the disability that they have. They are presumed to be helpless and therefore unable to make their decisions. They are also seen, or as people assume, that they have other disabilities other than the one that they can see, and more so this is on the aspect of intellectual disabilities, and therefore they are left out in many decision-making processes, and decisions are made on their behalf. There is limited budgetary allocation for the facilitation or even enabling of people living with disabilities to participate in various decision-making forums and processes. As I've mentioned earlier, there is dependency on caregivers. And in most cases, when a person with disability is invited to an event or a meeting, the budget allocations are normally for only one person, and therefore the guide is left out in this, and this limits their participation to some extent. Stigma and discrimination is another vulnerability that we see among people living with disabilities, and more so even at the places of work, and even in implementation of the Disability Act, especially when it comes to employment or even to provision of services for the target population. Next slide, please. Some of the community engagement plans or interventions or capacity building activities that we undertook is TB awareness through creation of the sensitization of people with disabilities in the various settings. People with disabilities are found in different settings, and there are many forms of disabilities, and therefore awareness creation is key through ensuring that we are reaching the population in the right mode, respecting their cultural and socioeconomic availabilities. Then there's engagement of people living with disabilities in the TBCSO forums for sharing and learning. We've had several forums where we have incorporated the people living with disabilities to learn from other civil society organizations and to ensure that they're also undertaking or taking up health and especially TB in their day-to-day implementation and programs. They have health programs, yes, but they focus more on the disabilities, and therefore engagement in these forums has provided an opportunity for them to share and also for us to learn on some of the implementation strategies that we can engage them in. There is participation in various forums to share experiences. Recently, we had a symposium where people living with disability were able to share their experiences and their recommendations, and even the challenges they face in accessing healthcare services. And this works in a way to increase knowledge or even increase awareness around the need for inclusion of people with disability in programming, and also provides an opportunity for exposure for them to also learn from others. Then there's engagement of the people living with disability in discussion panels. We have had several of these taking place, and especially around this World TB Day season, where people with disability were engaged in terms of TV and radio talk shows, and even in processions during the World TB Day to share information and also bring sensitize the populations that they too are also affected by TB regardless of their disabilities. Next, please. So these are some of the activity photos that we're talking about. On the left, there was a symposium that I've mentioned that happened last month, and we had the person seated is called Joseph. He's a person living with disability, and he became deaf due to multi-drug treatment. And the gentleman standing on the left-hand side of the screen is an interpreter who is sharing the experiences, the responses from the plenary with Joseph. And this is a milestone, and especially for TB, because previously we've not had interpreters being availed for various forums and meetings. And even in the World TB Day, this was an initiative that the National TB Program was able to take up and ensure that the people living with disability, and especially those who have had to hearing issues, then they are able to benefit from the proceedings of the various forums and meetings. On the left-hand side, we can see community sensitization by a champion who is living with disability, physical disability. She is able to sensitize the community and also show that they can also be TB champions in championing for TB people's rights. And therefore, this is something that the National TB Program is also taking up to ensure that they're prioritizing the issues around people with disability, even in the recently concluded National Strategic Plan. Next, please. Some of the outcomes of the capacity building activities that we've been able to undertake is of importance that we did as we started off the CELG program was a mapping of PWD organizations. This was important for us because we needed a starting point to be able to understand the forms of disabilities, what organizations exist, what programs are they undertaking, how can we leverage into the existing programs, what are the gaps that we can feed in, and this has helped us a lot in moving forward with the capacity building activities that are have been taking place and that are also ongoing. We have partnerships with stakeholders that has been established at the country level. This is very, very key because at the beginning of the project, we realized that stakeholders are key if we are to address the issue of ending TB and especially reaching the people with disabilities. So we have partners like the Ministry of Education who have come on board and this is part of embracing the multi-sectoral engagement and ensuring that no one is left behind and everybody has a responsibility towards supporting the initiatives around working with people with disabilities. There is the PWD organizations that have been considered for funding, and I think this is a major milestone for us in this implementation. As we are conducting our mapping, one organization, Kenya Union of the Blind, was able to come on board, and together with them, they saw an opportunity, and we worked on it to assist them in developing a proposal that was submitted to Stop TB Partnership Geneva, and we're happy to report that they got a funding, and this is a good outcome because then they are able to advance further a survey on TB and disability, and this is going to help us, the TB program, in defining or having activities that are responsive to the needs of the people and ensure that we are putting the people with disability at the center of the response. We also have TB champions who have been identified as interpreters, and this has also yielded the need for our TB champions to learn basic sign language skills. We've had one lesson so far with the TB champions who have been trained on basic sign language, and we'll continue having these forums to ensure that our TB champions, not necessarily those living with disability, are also able to communicate with the people with disability and especially through sign language. And we hope to scale that as well to healthcare workers. And I think that is one of our recommendations as well. There has been ongoing advocacy for inclusion of people living with disabilities at various committee and TWG levels. And this is something that will continue, will be ongoing. Next slide, please. Yeah, these are some of the pieces that we could fit in due to space, but Joseph there has, as shared earlier, has been engaged even in media coverage to be able to share his story on the national newspapers. He's also been engaged even at the WHO level, where he was able to speak on a WHO consular webinar to share his story, and he highlighted the importance of inclusion of people living with disability as people who can make decisions and be able to share their experiences and shape the response for TB. Stop TB at the same time was engaged again in, was involved in the development of the WHO policy brief on TB-associated disability. And this is where Joseph came in terms of ensuring that he's amplifying the voice of people living with disability, and especially more so as a result of having tuberculosis. The one on the left is the Kenya Society for the Blind. Again, through our engagements, they were able to also actively participate in raising awareness through their social media site on TB, and they'll continually be supported or capacity built to continue giving more information on TB to their target populations using their forums. And there are many, many more examples that we could fit into this. Next slide, please.
Joanne,
Yeah,
if you could run through, if you could quickly run through, because we are running out of time. We have 3 more presentations, please. Thank you.
Thank you. So some of the challenges, as I mentioned earlier, stigma and discrimination is not from the society, plays a big role in keeping the LMPs secluded. They self-seclude themselves. In mobilizing the LMPs, I think communication diversities was a challenge for us because some require assistive reading of emails. There was fear of being used for monetary gains, especially to the organizations, the small organizations that were reaching out. They were fearing that we would use their stories and their experiences to be able to gain money by ourselves. I talked about dependency, which increases the costs. And on building the capacities, the diversity of disability varied, and this necessitated, of course, working with different capacities at different times. For example, if you having the deaf in one sitting, then you may not have the hearing in the other based on the activities that you are implementing. Then again, sign language interpretation can also be very costly, and especially for those that use it as a day-to-day learning. And of course, lack of IC materials was also a challenge in the implementation. And many organizations work in silos, and therefore they deal with a specific disabilities, and that also brings its own challenges of having to ensure that you're engaging many partners in one, despite having the National Council for People Living with Disability, which is government. Yeah, next slide. I think we are almost to the tail end. Yeah, the needs that CELG must address to expand in these areas. Sorry. Yes, increase the resources to build the capacity. We need high-level advocacy, and especially to ensure that the policies that are developed are implemented and not just had on paper. Advocacy in countries to have, PWDs listed among key and vulnerable populations, especially for TB, so that they have defined allocations for funding, and then the funding for continuous research and development around this area. Next. These are some of the recommendations. Partnerships and collaborations are key. Capacity building, importance to invest in assistive technology adaptation, inclusion in the various forums. Next. Advocate for basic sign language, especially among healthcare workers. There is need for focused outreach initiatives. We launch programs that are dedicated at educating the KVPs about the significance of PPR and the methods through which they can actively participate, and as well as advocates for policy change to encourage the government to amend or even introduce policies that will ensure comprehensive inclusion of KVPs across all PPR platforms. Yeah, and this year's World TB theme was Yes, We Can End TB. And for us in Kenya, our bulb is well lit to ensure that we are missing and leaving no one behind. And that's it from Kenya. And thank you so much for the opportunity.
Thank you so much, Joanne. Thank you very, very much. Very good recommendations, outcomes as well. And it all talks about how do we, as we are building systems for pandemics, it means that we need to have community systems that are agile and capable to respond to needs currently for them to be able to respond to pandemics. So now I know we are out of time, and our next presenter is from Philippines. I don't want to, please, can you come in, introduce yourself? And if you can keep it short, that would be very good. Thank you. Over to you.
Okay, hi, I'm Shine Cathedral, and I will be sharing with you now the lessons that we have from our last mile population, the Tricycle Operators and Drivers Association, or TODA. I am from the Philippines and from the organization Action for Health Initiatives, or ACHI. Next, please. So a little background about our last mile population. The TODA, as you know, is the focus of of this project. So they have been seen as vulnerable, and they have risks such as basically in their work environment, firsthand, secondhand cigarette smoke, and other forms of pollution. Despite their exposures, their health-seeking behavior have seemed to be poor. Next slide, please. So our study also found out that based on our surveys, sorry, I'm being asked for my language. Based on our surveys, they have seemed to be weak when it comes to their community engagement and participation in health-related projects. The primary issue that we had in engaging with our TODA community is because they are daily wage earners, and they find it difficult to take time from work as tricycle drivers and participate in community or health-related activities. Next page, please. So next. So we've engaged them in our community engagement plan and interventions. For the costed community engagement planning workshop, we've invited around 16 members from 17 TODA groups, and we've discussed their engagement and their participation and their awareness. But their primary concern was firstly to raise awareness of TB health emergencies and TBPR. So that's why for the next page, we decided to conduct a TODA peer educators workshop, training on TB COVID-19. So primarily the goal was to engage at least 50 members of the to become peer educators and to 30 members by election. So wage earner status, we had an issue with their participation. So we invited them to take part in the training personally. And from that, sorry. So I want to repeat that. So we had a training. So we had 2 batches for this community for the TODA. So for training day 1, we had the background there. We gave them lessons on TB 101 COVID-19, and we shared to them what their roles are as peer educators. We've also had brainstorming on possible questions that their members would ask them. And then we had the assignment or where they will write their script for their TODA for their peer educators work. Next page, please. So for day 2, we gave them a week to prepare for their scripts. For day 2, we had them prepare. So we had them review the lectures and demonstrations and feedback. So they were able to share how they will do it when they return to their communities with their prepared script. And then we had the monitoring through attendance sheets that they will have their member side. And we also provided teachers and materials for them to distribute. We've also provided them certificates that they have become official TODA peer educators in their communities. Next slide, please. So next please. So these are the photos of the batch 1 and batch 2 TODA peer educators completers. So primarily the objective of this capacity building includes training them to become TODA peer educators and providing them skills and tools to facilitate their work as peer educators and support them in reaching their peers to provide and share knowledge on TB and COVID-19. Next slide. So we had a rollout of information dissemination by TODA peer educators. So as you can see, we had them conduct it in their community. So this is also a information posted on the terminal's bulletin board. This is not our instruction to them, but this is their own initiative. Okay. Next, please. So as for lessons learned, I would like to share that next slide. For locating the LNPs, so as mentioned, since they are always busy and daily wage earners, we have to gain their trust. Consistent communication and reaching out to them are essential. So meeting them in their place of work is significant to boost their participation in the project. As for mobilizing them, from planning to capacity building activities, most of them have raised the importance of support or incentives to ensure their smooth participation in similar programs. So the presence also of representatives from the government sector, NGOs, and support groups such as our network, the Philippine Alliance to Stop or PAS-TB, help boost the morale of TODA groups in participating and showing that they support and improve the quality of life of their own communities. So as for building their capacities, we have seen that they can become effective peer educators and leaders with proper training, sustainable materials, sustainable support, and motivation. And I think this is the most striking for me. Openly discussing TB-related stigma and discrimination has made some TB survivors of TODA become more open and speak more about their experience, even the experiences of their family, having had TB and COVID. Next slide, please. Recommendations. So I feel that when engaging the community of TODA, it's crucial to recognize and show them that they are important and they are the key players. So the project needs to support TODA in achieving a vision of well-engaged TODA community in decision-making platforms for health, TB, PPR, and other health issues. So this involves empowering community to identify their needs, determine how to access those needs, and decide which kind of assistance is required and who and where to turn for help. Next slide, please. Another recommendation from us is to capacitate and empower TODA champions to create a strong voice within the community and to enable them to also empower their communities. So we've seen potential champions as of now, and we hope to provide more trainings to them to become full champions who can talk about the needs of their communities. Next, we want to expand more about to other transport groups, such as jeepney drivers, bus drivers, and also for them to express, since they also express interest in joining networks, we can see how they can be supported as part of these groups. And lastly, we have CLM mechanisms in the country. We have Call Kalang's community hotline, and we hope that they can also be involved in TB CLM and to gather feedback related to TB and other health services. So that's all from my end. Thank you.
Thank you so much, Shane, and thank you so much for sharing the experience, especially connecting CLM to the work that we are currently doing. And apologies that I think you really, really needed more time, but it was quite interesting to just see how the TODA drivers, are coordinated and also participating and making decisions in how the capacity development they would want to to take place. So thank you so much for that, and well done. Now we are moving on to Cambodia, and Chanthron, we are going to give you a big challenge. If you could keep to only 8 minutes. Thank you. Please run through the slides.
Thank you, Olive, and hello everyone, and greeting from Cambodia. So I try to be shorter, actually. Yeah. So I just want to share with you all the lesson learned from Cambodia, especially what we work for around overseas effort to include the last mile population in the national TB and pandemic preparedness, prevention and response in Cambodia. Next slide, please. As you know, that this particular effort is come from the community engagement plan, and it was the result from the community engagement assessment that early conducted, and then the recommendation were translated into this particular community engagement plan. And then this plan, just to give you a very short some information, this community engagement plan we had budget around, or we proposed budget around 280K, and then for the actual implementation, we had only around 30K, to implement. So with a short, period of time. So just give you the background, as you know, just to give you that based on the result from the community engagement plan, all population, including TB key and vulnerable population, are left behind. So you can see, especially key population from TB program, and then other population are also left behind as well, especially the last mile population. In our context, Cambodia, we selected the internal migrant worker, our last mile population that we targeted. So you can see, especially the construction worker, especially people who work with painting substances, people living with slum area and other congregated setting. And then the finding also confirmed that the most affected, the affected population, have recognized themselves as vulnerable groups and face TB infection. So there are many factors that they reported. One is around working condition. Second is around working environment, and the last one, and also very, very important, is about the availability of TB services. Next, please. So in responding to the finding, so the assessments came up. So that's why the community engagement plan was developed to strengthen meaningful engagement of key and vulnerable population and last mile population in the TB and PPR response. So in that particular, community engagement plan, we produced or we developed 4 specific objectives. And then there are around 20 key activity intervention. So one of these was around, to ensure the inclusion of TB key and vulnerable population and last mile population, in the existing TB network. So existing TB network here in Cambodia, we refer to the national TB network that's called or known as TB People Cambodia, because we need to make sure that we have our existing structure in place and then make it stronger and stronger in the policy work. And then the second objective was around improve capacity building of TB key vulnerable and last mile population, to get how to say, to ensure that they equip necessary knowledge and skill on PPR in order for them to to proceed or to advocate with the issue. And then objective number 3 was around advancing stakeholder engagement for advocacy related last mile population. And then the last one, objective 4, was around addressing social barrier, including legal and mental health barriers. So social barrier here, we also refer to the social protection scheme that are available in Cambodia, and then how the last mile population can access those social mechanism or services. Next slide, please. So I mentioned a bit earlier, there are many activity intervention, in our community engagement plan. So otherwise we selected only few, to implement given a short period of time and also the funding constraint. And then we have selected 5 activities to implement, to be implemented. You can see one is around advocacy, meaning like to sensitize the key finding result from the community engagement assessment together with the community engagement plan, with high government official, from Ministry of Health, NTP, provincial health department, provincial health district, to ensure that they know exactly, who are left behind, especially last mile population, during the PPR permit, and also what they can do next. And then the second activity was, to organize session or meeting to facilitate the inclusion of the last mile population as a key members, as a core member, of the current existing network, as I said, the TB People Cambodia. And the third activity was, to discuss and assign for call point responsible for supporting the TB representative to be engaged in clinical meeting at CC level, at national level, and provincial level. So we need to have a specific focal point or last mile population rate. And then the last one, we also we also conduct the advocacy training for TB champion and TB community leaders to be ready for running policy and practices change to reduce discrimination and to promote equal access to services. Next, please. Next slide. Okay, this is just a very short result based on our selected intervention that I just said in the last slide. You can see one meeting was delayed. We really disappointed on that because of the time constraint. You may know in March there were many big events in Cambodia and also other countries as well, especially the World TB Day that we celebrated with a big manner. And then other three, were done or conducted. You can see one is the inclusion of last mile population to existing TB network, and then confirmed by the executive committee member of the TB network and their co-member from district level. They confirm they are happy to include last mile population, in particular construction worker, are part of their member. And then right now they are working with them to recruit more peer support group, to recruit more peer network, to represent in certain district and provinces. And then you can see we also recruit when we the TB network, TB people confirmed the inclusion, and then they started working with to recruit. And then right now we recruit or we establish over 20 peer support groups, or let's say 24 peer support group of last mile population, and then registered them as a member of the TB people, with a total of 388 members, you can see in the figure here. And then the last month, we just conducted the capacity building training on basic knowledge on TB, PPR, and last mile population, because we understand when we have to say we mobilize them, we encourage them to be a part of the TB network. So they need to have information, they need to have skill, to do some advocacy work, or to do some activity in their locality, their local area. Next slide, please. These are the pictures, from the activity implemented. You can see the activity from the establishment of a peer support group among construction worker. Our staff together with the leader of TB people Cambodia went to field, and then at night time, you may know that most of construction worker, they are available at or during the lunch time as well as the evening or night time. So that's why our team work in a flexible way to ensure to reach out those people, and also encourage them to be a part of the network. And next slide, please. So this the lesson learned that from the CELG project implementation. So regarding the challenge, we understand that the limitation of support and collaboration with the local authority because of security reason, construction owner, because of the loss of productivity or benefit. So it really hard for us, to mobilize more and more, construction workers to be a part of our activity at the ground. And then the timing barrier, as I mentioned, our team, went to the field with, we concerned about security because some of, construction workers also using drugs, and also, play, some bad things. So these are the concern that we have to say we face during the implementation. But otherwise, we have ways, to figure out. We had, we got a strong support from the NTP, provincial health department, and also regional health district, while engaging from chief of village health support group, or VHG, and the existing peer support groups, were actually, mobilize the construction worker in the local area, meaning that we can, we can reach them and also encourage them to be part, and also to be active in the peer support group, establishment process. And then our team also work, in a flexible time, as I mentioned, for meeting with the last mile population. And then we also building partnership and networking with the existing network, like I said, the TB people Cambodia and other key population from HIV program. So at national and subnational level. So these are, the way that to support our project implementation process moving forward. Next slide, please. And then this another one, and what the curl CELG can support further. So I think we have proposed to intervention. One is to advance the engagement and empowerment of last mile population representative in TB and PPR through capacity building. So that I mentioned a bit earlier that they are new to the network, they are new to TB, they are new to PPR. So that's why capacity building is needed for them. And then the second one is to provide technical and financial assistance to TB people Cambodia, to produce a directory or guidebook for last mile population, assessing TB, COVID-19, PPR, and also other related to services. So I heard, and also from Jem, he said during the opening remark. So that's why we will, explore, a way to ensure that the CSES, the existing CSES, or the upcoming Global Fund grant cycle 7, or the upcoming, Cooper grant, will be able to capture, to cover, some or specific intervention of this engagement plan, in the upcoming month or years. And next slide, please. And then it's how to say, there are specific recommendation from our side. So the first is to expand the awareness and sensitization of last mile population activity among TB management and service provider at subnational level, like I mentioned, because when we implemented the project on the selected provinces, but we need to expand the last mile population awareness among those provincial health departments, in particular the TB supervisor. And then the second one is to implement specific initiatives to strengthen the enabling environment for the inclusion of last mile population, such as partnership dialogue, stakeholder engagement platform, and so on. And the last one is to create a TB community partnership platform for promoting a meaningful engagement of last mile population representative at national and subnational level. Next slide, please. Okay, that's all from my side, from Ghana side. Thanks.
Thank you so much, Shanthram, for taking us through, especially on the lessons learned and linking it to the next phase. So the next presentation, because of time, I'm not going to comment a lot, but the next presentation is from Cameroon, and Bernadette is going to take us through. Bernadette, you have the biggest challenge in your hands, how to manage time. Over to you, Bernadette. Bernadette, are you there?
Bonjour à tous, je me nomme Bernadette. Bonjour à tous.
Bernadette, est-ce qu'il n'y a pas deux appareils près des échos?
Là, c'est bon. Ok, bonjour à tous et je m'excuse pour le petit bémol. Je me nomme Bernadette Bikotok et je suis chargée des programmes au sein de l'ONG FIS. Alors, sans plus tarder, je vais vous faire la présentation des leçons apprises de l'engagement des personnes déplacées internes dans la préparation et la réponse, dans la lutte contre la tuberculose, la lutte contre la COVID-19 et la préparation et la réponse aux autres pandémies au Cameroun. Slide. Slide. OK. Déjà, je ne peux pas parler de tous ces différents points qui vont cumuler le plan de cette présentation sans présenter les populations déplacées internes au sein du Cameroun. Déjà, la crise anglophone au Cameroun est un conflit complexe qui perdure depuis 2016 et qui trouvait ses racines dans les griefs historiques, politiques, linguistiques et socio-économiques du pays. Au fil du temps, le conflit s'est intensifié, entraînant des affrontements violents entre les forces de sécurité et les groupes séparatistes qui ont émergé dans les régions anglophones du pays, à savoir la région du nord-ouest et du sud-ouest. Et depuis 2017, ce conflit a entraîné la mort de plus de 6 000 personnes et contraint plus d'1 million d'individus à fuir et à être déplacés, ce qui soumet celles-ci à la discrimination, l'exclusion, la stigmatisation, la pauvreté, la limite d'accès aux soins de base, les traumatismes et la détresse psychologique, l'ignorance, le manque de communication et bien sûr les barrières de langue. Slide. Slide. Diapo. OK. En ce qui concerne l'engagement des populations déplacées internes, nous avons eu à mener une étude qui présentait notamment leur implication ponctuelle et les principaux résultats figurent ci-contre. On a notamment apprécié le niveau d'information, de collaboration, de consultation et la responsabilisation de celle-ci. Et on a remarqué que seulement 14,2% étaient au courant de l'existence d'organisations pour les personnes déplacées internes à l'intérieur du pays. 63,3% et 62,2% appartenaient à des groupes communautaires non enregistrés et ne participaient pas aux activités organisées par la structure en question. 93,54% ne savaient pas que le programme national de lutte contre la tuberculose existait. 92,54% des personnes déplacées internes ont déclaré qu'il n'y avait pas de mécanisme de consultation et de retour d'informations pour la préparation et la réponse aux épidémies, aux pandémies. Et plus de 50% des personnes déplacées internes ont déclaré qu'ils n'avaient pas été informés et n'avaient pas pu collaborer aux activités de préparation et de réponse aux pandémies. Slide. Diapo. OK. Comme principaux challenges et barrières de l'engagement de ces populations-là dans la préparation et la réponse aux pandémies, on a noté que les principales difficultés ici étaient la pauvreté, l'ignorance, le manque d'information, la discrimination, le manque de connaissances et de communication et bien d'autres. Et également, pour les principaux obstacles, on a noté que la discrimination, le manque d'information, la stigmatisation, la pauvreté et bien d'autres causes également étaient les principales causes. Et pour enrayer à cela, pour relever ces différents défis et améliorer la participation des plus démunis, les stratégies telles que l'éducation, la formation, la communication, les différentes campagnes de sensibilisation ont été formulées. Slide. Diapo. OK. Dans le cadre de la préparation de la réponse aux pandémies, des activités de plaidoyer clés ont été prévues et réalisées jusqu'ici sur la base des piliers stratégiques tels que informer les populations, les consulter, les impliquer, collaborer avec les différentes parties prenantes et les responsabiliser. Slide. Diapo. Diapo. Oui, merci. Nous avons notamment organisé des réunions de mobilisation des différentes parties prenantes pour les plateformes multisectorielles de préparation et de réponse aux pandémies de COVID-19, tuberculose et bien d'autres. Et également compris dans ces réunions-là les populations déplacées internes. Diapo. Diapo. Nous avons également produit un documentaire de 16 minutes disponible sur le lien ci-dessous, mettant en évidence les principaux besoins des personnes déplacées, tels que les infrastructures sociales, la stigmatisation, l'accès aux services de santé et bien d'autres. Diapo. 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 OK. Nous avons également encouragé via des plateformes de communication les IDPS à utiliser l'outil One Impact pour signaler les défis et les obstacles au service. Là, vous verrez notre point focal CELG passer sur la chaîne nationale qui est également l'un des acteurs clés dans nos différents groupes de travaux et dans nos différentes réponses. Vous verrez là également les photos des différentes séances de travail que nous avons avec les différents acteurs de préparation et de réponse. Et là, c'est lors de la journée internationale de lutte contre la tuberculose, nous avons organisé des campagnes de sensibilisation et de dépistage multimaladies. Diapo. Diapo. OK. Là, le 1er mars dernier, nous avons tenu un atelier de plaidoyer intitulé « Préparation à l'engagement communautaire dans la préparation pandémie » qui a réuni plusieurs parties prenantes notamment le ministère de la Santé publique, le ministère des Affaires sociales, les organisations de la société civile et également dans ces organisations de la société civile figuraient notamment les associations qui représentaient les populations déplacées internes. Et cet atelier s'est déroulé sous le lead du ministère de la Santé publique et du Programme national de lutte contre la tuberculose. Diapo. Diapo. Et enfin, pour pour ce dernier pilier, nous avons organisé des renforcements de capacité et d'autonomisation de 3 groupes de personnes déplacées à l'intérieur du pays, dans différentes villes du pays, notamment la ville de Yaoundé, la ville de Douala et la ville de Fumbot à l'ouest Cameroun. Diapo. Diapo. OK. Les activités de plaidoyer visent les résultats des activités de plaidoyer étaient notamment l'établissement d'un lien entre les représentants et les mandants sur différentes plateformes, la mise en place de plateformes multisectorielles pour la préparation et la réponse aux pandémies et la validation de l'engagement communautaire du pays pour les 3 prochaines années. Diapo. Concernant les différents défis, nous avons ici l'accès limité à l'information et le manque de reddition de comptes de la part des organes publics chargés de la mise en œuvre des politiques de santé. La participation limitée des personnes déplacées internes et la participation limitée d'autres parties prenantes, d'autres partenaires tels que les autres ministères chargés des questions sociales et financières. Diapo. Diapo. Comme besoin supplémentaire, nous avons souligné ici s'appuyer sur les associations existantes pour la mise en œuvre effective d'informations communautaires visant les personnes déplacées internes, car celles-ci disposent de ressources humaines et disposent déjà de connaissances sur le terrain. Comme besoin supplémentaire, avant d'élaborer le plan de communication accompagné d'un plan média, il serait préférable de réaliser une étude, voire une analyse des acteurs et des parties prenantes. Et comme besoin supplémentaire, nous avons également noté renforcer la collaboration entre les personnes déplacées internes et d'autres principales parties prenantes au sein des réseaux d'alliances et les coalitions sur les aspects de lutte contre la tuberculose, la COVID-19 et les autres pandémies. Diapo. Diapo. Comme principale recommandation ici, nous avons formulé le leadership du ministère de la Santé publique, à savoir au début du processus. Le chef de projet, FIS, a organisé plusieurs réunions avec les différentes directions du ministère de la Santé et du Programme national de lutte contre la tuberculose. Cela a permis de renforcer le leadership du ministère de la Santé tout au long du processus. L'orientation pour toutes les parties prenantes. À la fin de la réunion d'orientation, les principales parties prenantes nationales ont pris conscience des différents objectifs du projet et de la feuille de route pour l'évaluation de l'engagement communautaire. Comme autre recommandation, nous avons la collaboration entre les parties prenantes à travers les réunions, les groupes WhatsApp, des ateliers, des échanges continus et bien d'autres moyens de communication. L'identification de leaders influents au sein de la communauté, au sein de la société civile également, car ce processus a impliqué des discussions avec des municipalités locales pour identifier les leaders communautaires reconnus par leur propre communauté et les autorités locales, ce qui a permis d'obtenir les contacts pertinents qui permettent de mettre en lumière les véritables problèmes de la communauté. Nous avons également la promotion des leaders communautaires et enfin l'établissement de liens au niveau local entre les associations. Diapo. Diapo. Bon, là, vous verrez la photo de cette magnifique photo qui illustre parfaitement la cohésion et l'entente sociale entre les membres de l'ONG FIS. Malheureusement, ils n'étaient pas tous présents. Là, c'était juste une partie des de l'effectif de la maison, si je peux le dire ainsi. Et cette photo a été prise lors de la Journée internationale de lutte contre la tuberculose le 24 mars dernier. Je vous remercie.
Thank you so very much, Bernadette, for taking us through the session. I think yours was most challenging, but very interesting to see the things that you have done, especially even the video itself. I would like to encourage colleagues, if you've, once you get to the slides, please go and watch the video. It's quite informative. We only have a few minutes, so we will not open for a lot of discussion because of time, and we still have one more presentation. But however, there are some questions that were posted in the chat. There was one that was asking Joanne, what was the aha moment during the pandemic in Kenya? And I think Joanne has responded very well in the chat. I will also look at, there are other two questions that came out. That one is considering the aspect of reaching the last mile, particularly in monitoring former TB patients to prevent reinfection. Is there a replicable system that incorporates insights gleaned from the COVID-19 experience? And then additionally, how can such a system be adapted for addressing future pandemics? I will request Chanthron, if you can respond to that question. Considering the aspect of reaching the last mile, particularly in monitoring former TB patients to prevent reinfection, is there a system that is replicable that can incorporate insights from COVID-19 experience? And additionally, how can such a system be adapted for addressing future pandemics? As you are putting together your thoughts, Chanthron, can I also give this question to Joanne, who do I give? Bernadette. Could you just also can you talk a bit more around, since you started the CELG, what are some of the key results that you can say that these are the outcomes from especially implementing the engagement plans? If you can respond to that, but I would also like to ask, is there anyone else who has a question? If you can put up your hand, we'll just take one or two hands, but let me give the floor to Chanthron and to Bernadette. Over to you, Chanthron.
Thank you, Oliver, and also the colleague, asked the question. I think this is very, very important. I think from our experience, and I think it would be possible to include or incorporate the last mile population, into the existing report. Why I'm saying like this? For example, like Hannah right now is supporting to the national TB program on TB-MAS. So that's why the TB-MAS can be customized. So I think if the last mile population been integrated or identified by the national TB program as a key population or additional key population, I think the reporting system will be generated or will be, customized, in place. I think this is one way. The second way, we understand the roles of affected community during the COVID-19. For example, like in HIV/AIDS, in TB, the Global Fund, implemented the CM19. So that's why we have a specific reporting template and also the existing reporting template. What does it mean? Meaning that the SI, sub-implementer or sub-recipient for the 19 OM is another national center. Let's say National Center for Health Promotion. They really work specific on risk communication and community engagement. But in the existing sub-recipient or sub-recipient, they already have some activity around mitigating COVID-19 for the existing program like HIV/AIDS or TB. So they have a separate report. So I think this is also a good idea to harmonize together, how we can have a one system, I mean, for reporting system for COVID-19, and also including the last mile population. If any specific sub-discipline or implementer on PPR, so that's why it would be possible to include the last mile population. This is my response. I think I hope it will helpful, really helpful. Thanks, Olive.
Thank you so much for responding, Chanthrom, and based on the experience from Cambodia. So let's move on to Bernadette. If you could share what are some of the 2 key outcomes after implementing your engagement plans. Over to you, Bernadette. Oh, Bernadette, are you there? Or is there anyone else who would want? There you come.
Bon, déjà, lors des investigations sur site, on a remarqué que, de manière grosso modo, que ces populations-là n'étaient pas du tout au courant de ce qui était fait, de ce qui était disponible comme paquet d'activités minimum pour répondre à leurs besoins. Elles n'étaient pas du tout au courant de tout le mécanisme qui était mis en place, tant au niveau des organisations à base communautaire, tant au niveau des activités organisées par le Programme national de lutte contre la tuberculose. Elles ne savaient pas grand-chose pour la plupart. Donc ici, il est essentiel de les mettre au cœur de ces discussions-là pour qu'elles puissent répondre avec pragmatisme à toutes ces questions, notamment à cause de leur vulnérabilité accrue, de leur difficulté d'accès aux soins de santé, de la transmission élevée de ces maladies-là et pour des raisons de protection des droits de l'homme et d'équité des genres.
Olive, can I have one more, please? Olive, can I ask just 2 minutes, one more?
Yes, please. Yes, Bertrand, yes.
Yeah, this is Bertrand from Cameroon. So, as you say, one of the key outcomes, the PPA platform was formed, and then one of our key IDP who was part of the empowerment process was included on the PPA platform. That's the first key outcome. And the second key outcome, we empower 3 specific IDP groups in 3 different levels. So you see, for example, the first picture we have on the PowerPoint is now one of the key leaders from the IDP community who is part of all the activities at local, regional level, also engaged with the Ministry of Health as part of the new PPM platform was formed. And term of the reference of the PPM platform was also validated during advocacy meeting. Thank you.
Thank you very much, Bertrand, for explaining in terms of the outcomes, and which are very good, making sure that we have inclusion within PP, pandemic preparedness and response platforms. I see a hand from Chanthron. I think that will be the last, and then we need to hand over to Rain, who will be taking us into a presentation on copper. Over to you, Chanthron.
Thank you, Ali. Just want to respond to the question. I come, for example, like from Cambodia right now, the last mile population have been integrated as a key population, in the CELG assessment. So I think this is a very, how to say, interlink between the CELG project, last mile population, to the CELG assessment. And then right now, like James just shared about the key population, site information. I think this also in plan to include in our plan to include in that particular assessment as well, and then this been identified or agreed by the national TB program chair and team. I think this is how to say partially outcome of this particular last mile operation, effort. Olive, thanks.
Thank you so much, Chanthram, for sharing your experiences as well. So maybe we now move on to the next and the final presentation. And Rain has promised that she will keep her presentation for only 5 minutes. So Rain, over to you.
Hello, good morning, good afternoon, and good evening to everyone. So I'm Rain, and I'm the focal point for Copper Community-Led Monitoring, and I work closely with Olive, who handles our counterpart on community engagement. Next slide, please. So having heard from our CELG partners and the great work that they have done in ensuring community engagement in during the COVID-19 and post-COVID-19, we are actually transitioning and shifting now all our efforts from the COVID-19 mitigation towards the pandemic preparedness and response. Most likely you have seen the updated C19RM technical information note in 2023, wherein our strategy from the Global Fund perspective for C19RM, that all C19RM remaining funds has been shifted to move away from COVID-19 mitigation to broader pandemic preparedness and response, resilient and sustainable systems for health, and community system strengthening. So when we have this technical initiatives or strategic initiatives that is doing work on community-led monitoring and community engagement, we are also strategizing how do we provide the support that is more aligned with pandemic preparedness and response. And the CELG has already highlighted those key lessons, bringing upon from COVID-19 up to the PPR, and a strong justification and rationale why communities needs to be engaged in broader PPR spaces, platforms, and governance. It was the same lessons that we had in CLM in phase 1, wherein the lessons learned was actually not using CLM to mitigate the impacts of COVID-19, but how do we establish and support and strengthening existing CLM mechanisms that were designed for addressing AAAQ or availability, affordability, quality of services for HIV, TB, and malaria services, but for them to be established, for them to be able to be ready and capable and prepared to address and monitor future pandemics that might happen to us. And these lessons that we learned from CELG and from CLM C19RM phase 1 were useful for us to give a strong rationale to introduce COPPER, CLM, and community engagement. So COPPER for us stands for Communities in Pandemic Preparedness, and we see this being provided in through approaches through community engagement and community-led monitoring, which is mutually reinforcing to each other. But we see interventions that are crucial to strengthen CLM and community engagement through capacity building, providing technical assistance, and coordination as our key interventions to provide through these COPPER initiatives. But at the same time, there are other key areas of pandemic preparedness and response that is also happening as a provision of technical assistance coming from the Global Fund, which works could be in community health workers, antimicrobial resistance, community-based surveillance, or laboratory strengthening. And we see our efforts in community engagement and community-led monitoring being able to have synergies with these other PPR thematic areas. But at the same time, during the processes of C19RM, we did see increase of investments of CLM coming from the previous phase of C19RM, that there were increased investments in CLM for grant implementation in C19RM grants. But at the same time, coming from the grant cycle 6 to the grant cycle 7, that there has been an increase, dramatic increase of CLM investments as well. Next slide. To present to you the COPPER objectives for the 2-year implementation, I wouldn't read across the objectives of the 2 CMLI or centrally managed limited investments, but they are reinforcing and mutually similar to each other. Our first objective is generally on PPR literacy. We see it as a prerequisite, as an important integral part of our initiatives, where community engagement is working with our current partners, TB communities, as well as working with last mile populations. But we wanted it to expand to also include the other diseases and other civil society or communities that are working on universal healthcare or broader health emergencies. But for the CLM, of course, we are targeting with existing CLM implementers that are doing service monitoring for HIV, TB, and malaria. And all these target communities or participants that we have, we aim to provide PPR literacy for them to have a better understanding, comprehension, and valuing for the importance of PPR in their current work. But at the same time, for CLM, we hope that that understanding will translate to adaptations or changes or expansions to their CLM mechanisms, by definition, by adding, for example, a few additional indicators that are related to PPR in their current CLM indicators, for example. Our second objective is also similar as well. We aim to strengthen community, civil society, and CLM implementers to work together to be able to maybe form an informal coalition building or networking. But the reason for that is to be able to expand their work in terms of community engagement, the ability to just not work on TB communities, but working in other disease areas as well for PPR. But for CLM implementers, the idea of forming this coalition with broader civil society or communities working in health is for them that the data that they are able to gather through CLM and PPR mechanisms are brought to these coalitions or networks so that they can be properly used for decision-making in relevant PPR platforms at the national or the local level, or whatever it might be called in different countries. It might not be called PPR. But the purpose of that is to strengthen this capacity and coordination capacity of these different communities to be able to work together and make use of CLM data. And the third one is, of course, in line with evidence and learning. We see this as an approach for PPR can be considered as a new thing or can be piloted in this case. And we want to make sure that we are able to document these approaches on how community engagement is important to PPR and how CLM works in the context of pandemic preparedness and response. We want to document it to be able to show best practices and success stories, even to probably be able to provide a scientific literature in the effectiveness of CLM in PPR or RSSH. And we are developing all relevant tools, resources, convenings to be able to support that evidence and learning approach. So you can see the collaboration at least with these countries. Next slide, please. This is just a detailed list of interventions. I wouldn't read throughout it, but the difference in the approach is Copper CLM is predominantly a technical assistance approach. So we have technical assistance providers to be contracted, to be matched to our 15 priority countries, to be able to do different technical assistance support to the countries in terms of their literacy, training, adaptations of CLM mechanisms, up to the full cycle of the CLM, while the Copper community engagement is working its original implementation modality. We're in working with the 2 regional TB networks, working with the country engagement country partners, and also adding an additional country, as you can see in Liberia, for example. But the modality is that we community engagement works with implementers for a longer term, while the CLM or the Copper CLM works with technical assistance. It's also longer term because it's going to be provided in a series or phases of technical assistance approaches. Next slide, please. This is just a brief overview of what we are aiming to see. Of course, greater knowledge and capacity of communities and PPR, to expand and strengthen those partnerships between the civil society communities and CLM implementers, improve global knowledge on the understanding of community engagement and CLM and PPR, ensuring that we are able to integrate human rights, gender, and equity in our approaches to ensure that there will be greater and stronger community voices and leaderships to be able to use CLM data in these platforms and to have these systems in place to be able to contribute to systems readiness and pandemic preparedness. Next slide. This is just a summary of the countries that we are working in. We have 15 priority countries for community-led monitoring and 8 countries for community engagement with the addition of Liberia. And these are all countries that are part of the cohort countries for RSSH and PPR priority countries. And these countries also have synergies with other technical assistance that are being provided in other PPR thematic expertise, such as surveillance, community health workers, laboratory strengthening, and we seek to have those synergies with other investments that are happening here at the Global Fund level. Next slide, please. Out of those countries, there are 6 countries that we are very similar to Copper CLM and to Copper Community Engagement. And this framework of what you're showing is just how we see we'll be able to work together more stronger in these 6 countries, specifically Philippines, Liberia, Kenya, Nigeria, Cameroon, and Sierra Leone, and to work through them to the 6 years to make sure that there is stronger collaboration between Copper engagement, Copper Community Engagement, and Copper Community-led monitoring. Next slide. This is the last slide. Sorry, I think there was an error in the slide, but basically these are next steps immediate. Copper CLM had an open call for our request for proposals for new TA providers with an expertise on CLM, PPR, and community engagement. We have finalized the selection of the TA providers, and that is to be announced next week. Their IQC, or indefinite quantity contract, will start by April 15. It means by that time we are able to contract these TA providers and assign them to the 15 countries based on their TA needs. These are on-demand TAs, which means this is demand driven by the country team and the CLM implementer, and on when they need this CLM and PPR adaptation and technical assistance. But most likely the TA will be in more full blast around May. While the Copper Community Engagement implementers, they have already extended the contracts of their existing TB regional partners that will work together in the subcontracting of the country partners for community engagement. We are still in the process of identifying a country partner in Liberia as a new country for Copper Community Engagement. And for us to be able to kick off these 2 investments, we have, in 1 month from now, we'll have our Copper kickoff project inception meeting in Johannesburg, South Africa, which will bring all the partners from Copper CLM and Copper Community Engagement, including TA providers, PPR technical partners, for us to plan and work together and learn from the lessons from their previous phase and properly do a work plan for the next 2 years. But at the same time, since PPR literacy is a prerequisite, 2 days of that event will be dedicated to actually just a basic PPR 101 training for all our implementers and partners. And by that time, after the inception meeting and the training, where we will be able to focus on the full implementation of both Copper CE and Copper Community-led engagement initiatives as well. Last slide. So for any questions on that, you can communicate with me and Olive for anything related or questions regarding Copper CLM and Copper Community engagement. And I'll give the floor back to Olive.
Thank you very much, Rain. Thank you for meeting the challenge. I know it was quite very fast for you, and you cut off a lot of information. I know there's a question from James Mala from Stop TB Partnership around community-led monitoring, that there's one impact and how the Copper CLM will be working with one impact, or if maybe that's something that we could have a side discussion with James, if you do not mind, because of time. And with that, I would like to just say thank you, everyone, for participating in this webinar. It's been a long webinar, 2 hours, and a lot of listening, not a lot of interaction, but I think we've learned from this process. With this, I would first of all like to say thanks to ACT Africa and ACT Asia Pacific for hosting this webinar and for being at the helm of implementing the community engagement and leadership in pandemic governance. I would also like to take this opportunity to thank the Community Engagement Strategic Initiative Learning Hubs. We've had French translation and we've also had Russian translation. So thank you to Rame, thank you to EHRN, and thank you to IANASO for also disseminating and sharing about the webinar. I would also like to say a big thank you to our country partners. Without, especially the TB partners, because there's a lot of work that you have done. This whole project itself has been a lot of fast tracking from the assessment to the development of the engagement plans. And I'm happy that right now we can even start talking about COPA, both in terms of COPA community engagement and COPA community-led monitoring. And it is based on the foundation that CELG has developed. And we will see and continue seeing the leadership of the TB key and vulnerable populations within the specific countries. I would also like to say a thank you to our partner, Stop TB Partnership, to James Kiva, for being part of this whole process, for providing guidance and support, and also making sure that we working within the framework of the challenge facility, because I think most of the country partners that we are working with have had some implementation of around 10, which was around TB key and vulnerable populations. So thank you for the partnership and the collaboration. I would also like to say thank you to the team here at the Global Fund, starting with Jonathan, Rain again, and Sharon, and Gavin, and everyone else from the CRG team. Niluka, I think I should not forget to say thank you, because you coordinated and made it possible for the learning hubs to be part of this process. We are still going to be having a lot of other webinars, because the lessons are coming out. There are some documents that are being developed around guidance on community engagement and pandemic preparedness and response. There are tools that are going to be developed. So this is just the beginning of conversations. So with this, we'd like to say thanks to each and every person, everyone that has been here throughout the webinar, and we hope to see you again soon. Thank you. Merci beaucoup. Asante sana. And in Spanish? Gracias. Thank you. Over to you, Jeff. Jeff, you want to say something?
Can we take a photo together?
Okay, that's a good one. Okay.
Merci, au revoir.
If you can all open your camera, you can take a photo. You have 3 panels.
Hi, Win.
So
Win, how are you?
Everyone to open their camera.
Ça va, Bernard? Bertrand?
Comment tu vas?
Right.
Très bien, très
1,
bien.
2, 3. One more. 1, 2, 3. One last. 1, 2, 3. All right. Thank you so much, everyone.
Bye, everyone.
Bye.
Thanks and bye.
Je salue tout le monde. Au revoir.
Merci, au revoir.
Au revoir.
À la prochaine. Heureux de participer à ce
Au revoir.
webinaire.
À bientôt.
À plus.